Good afternoon. My name is Pankaj Jani, and I'm the president of COSECSA. I also am the vice chair of the board of the G4 Alliance. And what you're going to hear is partly because of the enthusiasm we received from Global Surgery Amsterdam 4 years ago. I'm really grateful to Matthias and Jure here for arranging this. I want to talk to you about COSECSA. COSECSA stands for the College of Surgeons, East, Central, Southern Africa. The college was thought of in 1996 and formally launched in 1999. The world started thinking about global surgery in 2014 when we met in London and launched the Lancet paper. So what is COSECSA? It's a disruptive, innovative model of training. These big words come from the US. When I gave a talk, they said, this is your model and you should include this in the slide. But it's the second largest surgical college with the widest area of coverage in Africa. This is what we were in 1999. Today, we have 12 member countries. And as I talk to you now, we have 450 trainees in 17 countries in Africa. And the population we cover is 500 million people. 5 billion do not have access. This is 10% of that. The success of COSECSA has been so huge that with 12 member countries, we've been approached by other countries in Africa that could you help us train surgeons? So we operate in Niger, Cameroon, Gabon, Sudan, Somaliland, DRC, Lesotho. These are the other countries. But the member countries are Kenya, Uganda, Tanzania. You're all familiar with this. Zambia, Zimbabwe, Malawi, Ethiopia, Mozambique, Rwanda, and Burundi, those small countries there. And last December, South Sudan and Namibia joined us. So we are 12 member countries, but we train surgeons in 17 countries. If you count the figure, there are 19 countries there. In 2 countries, we're still trying to get our act together. This is what we've grown to 2,000 in 2018 today. The mission of COSECSA is to promote access to and excellence in surgical care, training, and research. The jargon words which we usually use, but what are we trying to do? It's a college which is disruptive and innovative because it's a college without walls. All right? We use the national resources to train the surgeons. Primarily, these are health delivery institutions, which are the provincial hospitals, the regional hospitals, the mission hospitals or faith-based hospitals, and private hospitals to train surgeons out of the metropolitan areas. Who are the trainers? These are the practitioners employed by the government. Who are the trainees? These are the medical officers working in those hospitals and paid by the government. The whole country becomes a training ground. The problem we had in the past was that students would relocate from the rural areas to the capital city, train there, 5 years of undergraduate training, 5 years of postgraduate training on an average. Who would leave the capital city after 10 years? Nobody would go to the rural areas. So 85% of the surgeons served 15% of the population. These were the figures in the past. Over the last 10 years in Kenya, this figure has changed from 60 to 40. So we've got 40% of the surgeons now in Kenya working in rural areas. We have 106 accredited hospitals. We're not training at all of them. 12 were accredited in the last 4 days in Kenya, 12 more. And as I was leaving Nairobi, the last one, Meru District Hospital, was being accredited in Nairobi by the board. 66% of our accredited hospitals are outside the capital cities. This is why it is innovative. That's the council of COSECSA, all right? From the 12 countries, each surgical society nominates 2 members to the council, and then we have the executive and the secretariat, and this is how we run the college. What are the numbers? The unmet surgical burden in Africa has been a particularly hard issue to solve. So we are just involved in training the human resource part of what is the full ecosystem required. The developed world has 5.8 surgeons per 1,000 population. We have 0.5. Don't ask me which is the one, upper half or lower half, I don't know. What are our achievements? We've graduated 261 specialists so far. We have 450 in training. We have trained 290 trainers, of whom 28 are master trainers. This figure jumped to about 40 when we trained 12 in Dar es Salaam 2 weeks ago. We have 1,102 members and fellows. This is the actually hospitals which are training. We have regional suite of short courses. We do a lot of courses, as I'll show you. We have a comprehensive e-learning platform, and this is being revised in 2018 with the help of a medical educationist from Rhode Island, right, in the US, who's a surgeon and trying to tell us how we should teach our surgeons. We have a bespoke electronic logbook that records everything. And we advocate for essential surgery in countries. The context is different in Africa. If you go to Malawi, there are no doctors to train as surgeons. So they're clinical officers who are being trained, not by the college, but by the other thing. Our mandate is to train doctors or physicians, as the Americans call it, to surgery. And we've established women in surgery in Africa. So these are the numbers. These are our achievements. In 2003, we examined 7 membership of the college candidates. And last year, 2017, we examined 57. These guys do 2 years of training, and the emphasis is on basic surgical sciences, principles of surgery, emergency and essential surgery. These are the fellowship candidates, and you can see there are various specialties: general surgery, ortho, urology, pediatric, plastic, neuro. We've added ORL, otorhinolaryngology, and neuro, but our focus is to train general surgeons. These are the numbers of graduates. 261, as I mentioned, is the figure we have trained so far. We started with 7 in 2006, and last year we examined 55. This year, 2018 in September, the first Wednesday of September is our written exams. We had 77 membership candidates and 100 FCS candidates. So if all of these pass, I'm telling you, we have a mind-boggling task in Kigali in December where we do the exams to examine all these candidates. So what are the facts? Why are you all here? I believe you are all champions. We lose 1 female every hour due to pregnancy-related complications. Look at the Mary Stopes report in Kenya. It's in the Nation newspaper, 22/8/18. This is very Stokes. It should be very Stokes. 3 deaths every day due to abortion in 10 to 24-year-olds in Kenya. I'm talking about Kenya here, which is the best placed country as far as I believe out of the 12 countries. Kids with congenital deformities, we have 7,000 clefts walking around in Kenya. Facts with Smile Train, Operation Smile can be achieved. Who is a boda boda driver? If you want to come out of poverty in Africa, you buy a motorbike, 2-wheeler, whatever you call it. It costs 35,000 shillings, $350 to get a 2-wheeler. You start your business, you're trying to get your family out of poverty. 1 fall and an open fracture, you become a liability to your family. That's what we are witnessing. Cataracts in the elderly, we have 200,000 people walking blind in Kenya. 100,000 of these have cataracts, which can be sorted out by a 15-minute operation. Just 15 minutes by a non-physician provider. These are the facts. COSECSA's impact. What is our impact? We have 177 MCSs and FCS candidates for this September exams. We've taken the exams in 18 countries. You see, these figures vary because one candidate who had done his MRCP or MRCS in London, in Madagascar, wrote to COSECSA and said, I meet your requirements to do the exam, so can I sit the exam? So the council deliberated in Malawi and allowed him to sit. So these country things change from time to time. This is the spread of the various specialities that we offer and the countries where the training is going on. 22% of our trainees are in Kenya, 19% in Zambia. These are the 2 most successful countries which are there training surgeons, and I think we'll be able to answer the problems of surgery in the next 10 years. I'm sorry about that. The surgical workforce in numbers. This is important. We did an analysis, but this includes 10 countries because Namibia and South Sudan had not joined us by then. We were 10 countries. The total number of surgeons in these 10 countries are approximately 2,400. I'm talking about general surgeons basically, but it is not accurate. You have ENTs and all these mixed according to the figures from the board or the ministry or wherever. The total number of surgeons trained by COSECSA is 261, and the trainees are 450. They add up to 711. Today, as I talk, approximately 33% of the surgical force in the EXA region is from COSECSA. Part of this credit goes to GSA, Global Surgery Amsterdam, for helping us, supporting us, and giving us the incentive to do this work. Thank you. 50% of all the surgical trainees in the EXA region are COSECSA trainees today. I think this number will be overtaken in the near future. Achievements, what are our graduates doing at the present moment? The members who are in training do approximately 260 operations per year, covering emergency and basic surgeries. I'll show you how we record this. This is an accurate figure, okay? Fellows perform the most other needed procedures. We have e-logbooks from we get these figures. 260 times 200 is 52,000. 450 trainees times 150 is 67,500. By 2020, we're expecting to do 250,000 operations, but today, we're doing 120,000 operations per year. The 5 million figure has come down. Retention of graduates, we're concerned about this. So offering high-quality local training opportunities is key to retaining medics in the low-income countries. 93% of our graduates work in rural areas as we talk. They're retained in Africa, and majority of them work in rural areas. How's our training? It's assisted by e-programs. This does not replace the apprentice model of training or the humanistic model of training that I'm going to tell you, but it aids, it enhances the training through electronic programs. We have an e-registration, e-learning program, which is School for Surgeons. We're fortunate, the Royal College of Surgeons of Ireland gets to help us. Irish Aid gives us the money, and we have a collaboration program with RCSI. So I'll tell you a little bit about that. We have e-logbooks, which records everything. I'll show you a little bit about that. We have e-skills training, e-CPD is planned, and we plan to do e-exams in the near future. Because of our success, there's a College of Nursing now. This is the College of Surgeons. We have a College of Pathologists, Ophthalmologists, Anesthetists, Obs-Gynae, and Physicians. The curricula of OB-GYN, Anesthetists, and Physicians are at the present moment with the boards, and they're trying to approve this curricula, and then training will start. But you need champions. We also are cognizant of the fact of gender balance. 13% of our trainees are female candidates. We started with 7%. The quality of training, this is what we are very concerned about, and that's where we request for help. It's competency-based training, but we're realizing that the culture of surgery is the most important thing in training surgeons. This is our platform, School for Surgeons. You can go through it. This COSECSA, RCSI, we have various projects associated with that. There are interactive modules put on this, mandatory modules that you have to do, all right? And we believe surgery in Africa is different from surgery in the rest of the world. So we try and help to add other topics pertinent. So the mandatory courses, strict online logbook, continuous assessment, fellowships across 19 countries. This is the evidence-based model of training, knowledge, skills, attitudes. That's what we talk of, all right? The traditional model is the trainee's attention decreases after 10 minutes to about 20%. So we have a constructivist method of training. I think you're all familiar with that, the flipped classroom and all that. I won't go into that. They construct their own model of training if they want to learn by discussions or things like that. This is an example of the module on shock that will roll out from 2019. Week 1, they deal with hypovolemic shock. Week 2, week 3, week 4. This is how the objectives are. This is what they want to read. The definitions, how it all comes about, and then we're cognizant of the fact that you need international evidence to back up what we're doing. Psychomotor skills, this we were in the skills lab today. We usually advise our trainees. So skills are psychomotor, communication, and clinical decision-making skills. We try and create a basic surgical skills lab in each hospital. This is very basic. Each hospital is supposed to have this. This is not there. It's being worked on, but in Kenya, most of them have them. So we show them how to tie knot, suture, bowel anastomosis, and all that. They have to do 25 hours of training before they can handle patients. This is our Nairobi Surgical Skills Center, and we have skills labs in each hospitals. These are the students doing Nairobi Surgical Skills. This is an endoscopy course that I'm running. Innovative e-logbook launched in 2015-90. This is 150,000 operations logged at the present moment. We're trying to see how to assess competence of training from the e-logbook. We're still working, trying to use our brain. We're not there. We give a score about complexity, what's your role, and then we give a value. These are the common operations logged from the e-log books, and minor, intermediate, major, and then we try and find out who is doing what and how it's going. The formative assessments are also logged on the e-log book, and this is how we assess our trainees. Examinations in December 2017, the first cohort who had used the e-log book sat their exams, and various forms are logged onto this logbook. The trainees self-assess their progress, and feedback is one of the most important things in training. We train a general surgeon to do emergency and essential surgery, open fractures, internal fixation, cesarean section, ectopic skin. This is the true general surgeon that we are training. In 20 years and in 17 countries, our organization, COSECSA, has developed surgeons who serve on the front lines in some of the most challenging places on earth. In a concerted effort to close the gap of unmet surgical need, there's a huge gap of unmet surgical need, and the most challenging places on earth. Some of these surgeons operate with clinical officers who are anesthetists, all right, treating the most sick patients. In a concerted effort to close the gap of unmet surgical need, the African nations, we are trying to teach them to care for themselves. Okay, it's a unique thing that's going on at the present moment. This is what we were, 1999, 2018. This is what we hope to be in 2020. Our mission for the future, this is Kenya. I'm just going to take one more minute on Kenya. 47 counties, 80% of surgeons with 80% of the district hospitals with no surgeons, 90% of the district hospitals with no anesthetists. We're looking at the density map. We don't need to train surgeons in that area where the density is low. We're looking at the density map. These are the hospitals which were being accredited last week. These are the accredited hospitals. The list of the hospitals which we are accrediting, we have 257 district hospitals. I plan to train 771 surgeons in the next 10 years, so that there'll be 3 surgeons at each district hospital. 771, you need 77 per year. These are the numbers we are training, and we need to convince 10% of the doctors coming out to take up surgery. That's another important task. Partnerships are important. We're partners with RCSI, PACS, Oxford, and all these people, including GSA. Our challenges. Funding is always a challenge. More improvement of the hospitals from the government. We're working on this, and it's moving, because in Kenya there are counties, and each governor is concerned about his county. So these are some of the problems, but we need more passionate champions like you in the room. So how are we trying to do this? We're trying to get the neglected surgical conditions to be attacked by the international organizations and improve the hospitals at the same time. Visiting faculty support, how can you be part of this? Visiting faculty support, sim labs, you can support a course. For 25 trainees, it costs us about $500. Support an expert trainer rotation. We have expert trainers in Kenya who could go down and teach these people, $500. Support a trainee rotation, and support a training surgeon, $5 a day. It costs for 5 years to train a surgeon. I think I've said enough. That's the end. Thank you.